Welcome everyone this afternoon to the third in the series of CNET's supportive care webinars. My name is Lyn Gaetz. I am a NETS patient. I'm on the CNET's board of directors. You may have heard me. I was a panelist in the first webinar on palliative care. Today we are so fortunate to have Dr. Daniel Rayson as our presenter. He is a medical oncologist at the Queen Elizabeth II Health Sciences Center and professor of medicine at Dalhousie University. He completed his medical training at Dalhousie, followed by an internship and a staff ER position at the Toronto East General Hospital. He then moved on to a fellowship in internal medicine and hematology medical oncology at the Mayo Clinic in Rochester, Minnesota. His main area of clinical care and research activities are in breast and neuroendocrine oncology. He is the chief of the Division of Medical Oncology and has been chair of the Multidisciplinary Neuroendocrine Tumor Group in Halifax since 2012. Dr. Rayson will go through all of his slides and his whole presentation, and we'll take as many questions as possible at the end. You can just type your questions into the chat and we will address them all as we come to the end of the presentation. So I'm just going to turn it over now to Dr. Rayson. I'm sure you're going to enjoy his very informative presentation on everything you may have wanted to know about NETS and shouldn't be afraid to ask. Thank you very much, Dr. Rayson.
Thank you, Lyn. I wish I could see you all, but this is obviously the new reality, and thanks for joining us this afternoon. So for those of you my age and older, you probably know that this title of my talk is stolen from a classic book and movie about a different topic. For those of you younger, just ask your parents, okay? So now, what I hope to do is over the next 35-40 minutes is to cover some basic principles and questions, and I'd never be so presumptuous as to assume we could cover all your questions, but I hope I'm going to hit the highlights and hope you'll find this informative. And the first question that oftentimes comes up, particularly at diagnosis, is, I have a what? And I'm sure if we were together in the same room, I'd see a lot of nodding heads. You know, most of society has a general sense of what breast cancer could be, what lung cancer could be, what colon cancer could be, because they're confined to an organ that we can understand. But we don't have a neuroendocrine organ. We have a neuroendocrine system, and nobody really talks about it. The system runs throughout our body from the top of our head to the tips of our toes, and the cells in the system look like this, and they're normal. They're mixed with all our other cells. And when they're present normally, there are a few of them, but when they start growing out of control, they become a lump or a tumor or a mass, and they look like this. No matter where in the body a neuroendocrine tumor starts, under the microscope, they look remarkably the same. You know, when I explain to patients what the neuroendocrine system is, for those who are interested, I kind of bring up an analogy of a big city, right? So you can build the buildings, but if you don't have the plumbing, the electricity, the road work, the communication systems, that city is not going to work. It's going to become very dysfunctional. The neuroendocrine system is akin to all the systems that support a big city, whether it's garbage collection, whether it's a sewage treatment plant, whether it's the electrical grid. Our neuroendocrine system is involved with all those processes everywhere and is a critical part of us maintaining our daily function. Now, when neuroendocrine tumors develop, because the system is everywhere, they can develop in multiple different places, of course. And this is just a cartoon that demonstrates the most common sites of origin. And you can see over half arise within the small intestine. About a quarter involve the lung system. And about 20% involve the pancreas area. And then there are other rarer areas of origin, such as the thyroid gland, some lymph nodes, the ovary, the cervix, They can start in the prostate and they can start in the skin. So that's one of the reasons why it's been very difficult to get a coherent picture of neuroendocrine tumors historically, because they arise from different origins and cause different problems. And I'm not going to go through all this, but this just gives you an idea of some of the hormones that are involved in normal neuroendocrine function. And so if neuroendocrine cells are not working normally, there can be a variety of hormonal problems that many of you understand can cause a series of potential symptoms. So with that, one of the second questions that oftentimes is asked and can take quite a long time to understand and to incorporate is, why was it so confusing when I was diagnosed? So the diagnosis is often very poorly communicated, and sometimes that's due to a lack of knowledge. Sometimes it's due to where it was diagnosed, whether it's in the emergency room, whether it's with a family doctor. It often comes out of the blue. No one expects to ever be diagnosed with a neuroendocrine tumor, and I can tell you from the other side, no doctor ever expects to diagnose someone with a neuroendocrine tumor. And so at the time of diagnosis, there's often a complete shock and a bit of a stunned environment. It's poorly understood by the general medical community, and I know I don't have to convince anybody on this webinar about that. I was a medical student, I was an intern, I was an emerge doc, I was a GP. I had never heard of neuroendocrine tumors. And in fact, even during my first 3 years of my internal medicine training, I may have heard the term a couple of times. So very poor, historically very poorly understood by the general medical community. At diagnosis, as I think everybody understands, there's often very little information to go on besides just you have a neuroendocrine tumor. And so much of what comes next is trying to get more texture, a better understanding of the disease and what it means to you. And so at diagnosis, the information is oftentimes very incomplete and very sketchy. And of course, it comes in the context of a general terror of a cancer diagnosis, which is a horrific shock for everybody, no matter what the disease is. And sometimes there's an element of what I call catastrophization. In other words, it's a cancer and it's compared to every other kind of cancer. And a picture is painted that's so bleak and so devastating that it's very hard to recover from. And at other times, because historically some of these tumors have been thought to be almost benign, the diagnosis is sometimes very minimized when that's not right either. And of course, there's a whole spectrum in between. So many patients often find the time of diagnosis a time of utmost confusion, and depending on how it's communicated and what information is available, people can be led down some very, very wrong paths. So neuroendocrine tumors used to be called rare. We don't think they're really rare anymore. They're uncommon, of course. And I'll just show a couple of numbers. This is the best data. It's actually out of Ontario that looks at the number of diagnoses of NETs over a 15-year period from 1994 to 2009. And you can see here that for all cancers, the change in diagnosis rate was about 13%, but over the same period of time, for NETs, it was 138%. So definitely more patients are being diagnosed with neuroendocrine tumors. We don't think this is because there actually are more, to be honest with you. We think it's because our radiologists, our pathologists are much better at identifying and diagnosing things correctly. And there are many examples of patients who were previously diagnosed with a colon cancer or a lung cancer who likely would have had a neuroendocrine tumor if the diagnosis had been done correctly. And because patients with neuroendocrine tumor, thankfully, many do very well, for long periods of time, the prevalence, in other words, the number of patients who are actually walking around in your neighborhood, in your city, in your province with this disease, with a GI neuroendocrine tumor, so a neuroendocrine tumor of the bowel, there are more patients with those than there are with stomach cancer or pancreatic cancer combined, even though so much more is known about those two diseases, because unfortunately, those diagnoses tend to lead to very poor survival. So both those facts lead to some very interesting new data about the scope of neuroendocrine tumors and has resulted over the past 10 years, 15 years, 20 years of a much broader recognition, although it's still not great in some places. So a next kind of obvious question and one that we get asked a lot is, how did this happen? And is it hereditary? Well, the answer is very unsatisfying. For the vast majority of cases, we simply don't know why this arises. And we're probably more in the dark about neuroendocrine tumors as compared to many other cancers where we think we understand a little bit better as to the origins. Again, I won't go through this, but if you look at this slide, you'll see the term sporadic, okay? And sporadic simply means no identifiable hereditary or genetic link. So most neuroendocrine tumors are sporadic, but some have a higher incidence of a genetic syndrome, and patients can be referred for genetic counseling and testing. And we really don't know how many patients actually do get referred for genetic testing when they're diagnosed with a neuroendocrine tumor. Probably a lot fewer than should be. But there's still a lot to learn in terms of genetics. And as far as how this happened, most times we have honestly no clue. When did it start? Well, that's not terribly different from all other cancers. We never can date stamp when a cancer started. I always tell patients, and some of you, if you're online, you're probably rolling your eyes because you've heard me say this, is that if the first cancer cell turned someone green, we'd be so much further ahead in terms of cancer treatment and outcomes. There is no ring, tree rings to help us date stamp it, and we can't carbon date them. So we never know when it started. But we do know it started a long time before diagnosis. Why wasn't it diagnosed sooner? And that's a very common question. It's a very common issue. It's been discussed in many different areas in many different ways. Maybe a few answers or thoughts to help with that question. The first being that, as many of you understand, many cases grow extremely slowly without any symptoms over years. When most people think of a cancer, we think of it as an aggressive, destructive process. We think of the symptoms associated with cancer, and we all have a picture of what that is. But we know that many patients with neuroendocrine tumor have tumors that grow extremely slowly. And when that growth is slow, actually, organs have a chance to adapt. And what I tell patients is sometimes these tumors can grow and just nudge space for themselves rather than being intent on destroying the tissue. So many cases grow extremely slowly because, and with that slow growth, the body adapts. And so without any other symptoms associated with it, nobody would ever suspect a neuroendocrine tumor, and certainly not least the patient. We know that many patients do have symptoms, and we'll talk a little bit about some of the syndromes that can come with neuroendocrine tumors. But for those of you who have been diagnosed with a syndrome, particularly carcinoid syndrome, for example, we know that the symptoms are often called a million other things before it's correctly diagnosed. Again, I'll bring back my own personal experience as a GP and an emerge doc. With diarrhea and flushing, there were about 50 different diagnoses that came before a neuroendocrine tumor. So as frustrating as it is, Unfortunately, the symptoms can mimic many other benign conditions, and I'm sure many of you have stories to share in that regard. We know that, and many of you understand that the most sensitive tests for neuroendocrine tumors are not always readily available across Canada. So even when there's suspicion, many times access to the right tests might be lacking. And again, just reinforcing what I mentioned about the diagnosis, typically in medicine, when we hear hoofbeats, we think of horses, not zebras. And so I know this issue is a huge frustration for many patients, and I'm sure it's something we'll have questions about in the Q&A session at the end. Now, of course, the desperate question for many patients that come to us is, can it be cured? Again, our hope is with time, we'll be saying yes more and more. For now, many can be cured, but only if surgery is able to be done to completely remove the tumor. And I'm just showing you some circles here, and I'll just very briefly. So if you can see my arrow, the CAT scan with 3 circles is a patient who had a neuroendocrine tumor of the small bowel, along with, it's difficult to see here, that's why the circles, 2 small liver metastases. This patient was able to have curative surgery because the surgeon was able to remove the center mass and was able to remove the 2 areas in liver. The patient at the bottom, however, had disease all throughout the liver, and the liver was dramatically enlarged, and there was really no hope of being able to surgically remove all of this, and so that patient could not be cured. So the question of cure really comes down to our surgical team and where the disease has spread to, how much, and what the technical issues are about potential surgery. For many of you with a neuroendocrine tumor, after and a biopsy is done to make sure the diagnosis is correct and is the right one, you'll hear a term called a Ki-67. And what is this Ki-67 I keep hearing about? Well, it's a test that is done in the pathology lab, and it should be done in every pathology lab. It's very easy. There is really no excuse in 2020 not to have that done. And it's very important because it gives us a sense as to how active the cells are. And by active, I mean how quickly or how fast are they growing. And I'll just draw your attention to the bottom 3 slides here where you see all the brown dots. You can see that on your left, there's a slide with very few, if not any, brown dots, some more in the middle, and a whole lot on the right. Those brown dots represent cells that are actively growing. And the Ki-67 index is just the percent of brown cells versus the total number of cells. So it might be 0% on the left, 4% in the middle, and 40 to 60% on the right. And that's the Ki-67 index. Okay. The problem is with Ki-67, if you take biopsies at different places, you may get different Ki-67 indexes. So it's not perfect by any means, but it is a very important test that helps us plan next steps in the evaluation of things. Many times after diagnosis, and especially if patients have symptoms before they're diagnosed, and some don't, some patients are diagnosed completely by chance. The next question is, well, did this tumor cause my symptoms? And the answer is sometimes. So I'll just briefly describe. So in the top left here, this lump in the middle resulted in this patient having about 10 admissions to hospital for bowel blockage and bowel pain over about 5 years. It would happen about twice a year. That's it. It would always settled, and it took about 5 years to diagnose this neuroendocrine tumor. and the diagnosis was made just by this CAT scan. This patient with this very large liver had about 2 hours of pain that he thought was his gallbladder. He went to the emergency room because a colleague at work told him he should to get his gallbladder checked out. And this was a scan from the emergency room showing a massive liver. So that person had probably this disease growing for 10, 15 years without any triggering symptoms. And finally, on the bottom, you see these yellow arrows. There are these little specks, that one little speck here. And this particular patient was having terrible trouble with very low blood sugars, to the point where she was passing out and having seizures and had 3 car accidents over about 3 years before she was diagnosed with a neuroendocrine tumor of the pancreas that was making too much insulin. So again, if you look at the spectrum here of these 3 patients, you can get a sense of how difficult it can be to sometimes come to a quick diagnosis in regard to neuroendocrine tumors. And then we know over time, patients with a particular syndrome called carcinoid syndrome oftentimes develop flushing, which again can be mistaken for many benign conditions, and over time can develop a problem with the heart valves. I'm showing you this just to show you. On the left is a normal heart valve. It looks very thin. That's the way it's supposed to be. And on the right is a heart valve from a patient with carcinoid heart disease. Again, a problem that comes after years of someone with carcinoid syndrome that is not controlled. So I'm sure everybody who's listening has their own particular symptom complex that some of you identify with some of these patients, and some of you, again, are totally unique. And that's what makes this area both so challenging and so interesting, and sometimes so difficult. So the next question is, what special tests might be recommended for me to have? What might be the next step? So oftentimes, and many of you have had this done, something called a chromogranin A level. It's a blood test, and a chromogranin A, very importantly, can sometimes be helpful to monitor the disease, but it can sometimes be also misleading, depending on the type of medicines you're taking and depending on how your kidneys dispose of things. Very important that a patient can have a chromogranin A level of 100,000, and that doesn't do any harm. So it's not a blood test like a hemoglobin or a blood sugar, where when it's very high or very low, you're going to feel that. Chromogranin A is just a numerical number that does link to the amount of disease in your body, but the number itself doesn't hurt you. And there are blood tests that can check for hormones if a patient has symptoms that suggest there's a problem with the hormones. So that lady I mentioned to you about the high levels of insulin, that would have been diagnosed through blood tests. Then we have the dreaded, I shouldn't say so dreaded, but for those of you who do this regularly, sort of annoying 24-hour urine test. And this is done for a couple of neuroendocrine tumor situations. One, patients who have carcinoid syndrome. So that lady I showed you with the flushing and the heart disease, she would have had that done to diagnose the carcinoid syndrome. And some rarer neuroendocrine tumors also will do 24-hour urine collections to look for their specific hormonal problems. And finally, there's a set of X-ray tests that are really very unique to neuroendocrine patients and play a very important role at helping us follow and decide what treatments might be best for which patient. So I'm going to go through these very briefly a little bit. Now, many of you have had octreoscans scans, and many of you have had PET scans. Some of you have had both. Some of you have had one for years, and then you've had the other. What's that all about? So Octria scans can be very helpful for, if you look below, patients with low grade, very few brown dots on the slide. So for Octria scans are very helpful for slow growing, what we call well-differentiated neuroendocrine tumors. In red are PET scans. Now PET scans is a totally different test, and PET scans are most helpful to look for tumors that are very rapidly growing. So some patients have tumors that are all slow growing, and they'll always have Octria scans. Some patients have tumors that are very fast growing, and they'll always have PET scans. And some are in the middle. Okay, they have a mix of cells, or they're in the middle of these brown dots and might need both tests to further clarify what's next. So I hope that helps sort out some confusion that sometimes arises with these tests. And I'm not going to go through this, but I just, it's only fair, I think, sometimes that you actually see what this looks like. So in the middle is the octreotide scan, and you can see these tumors show up as almost basically suns, stars, okay, just bright, shiny objects. And they can look very differently depending on whether an octreotide scan is done in the middle or a PET scan is done on the right. If you look at the blue circles, same tumor, same patient, very different look. Again, it just gives you a sense of how these different tests work and why sometimes people have multiple tests. And then, as many of you know, in Canada, we are a little bit behind the curve in terms of a new test called gallium-68. We've relied very much on our colleagues in Sherbrooke, Quebec, and their expertise for this much more sensitive test. Compared to what you see on the left is the Octria scan. And I think almost anybody, you don't have to be a radiologist to know that the scan on the right is much more sensitive at detecting tumors. Gallium-68 is coming, and it's coming soon, and we're all looking forward to it. So when patients come to medical oncology and they're discussed at the neuroendocrine tumor group, of course, the next big set of questions are, what about treatment? And typically, when this diagnosis is discussed or when patients realize they may have a cancer, the first treatments that are jumped to is chemotherapy or radiation. But as many of you know, in general, most patients with neuroendocrine tumors do not need chemotherapy or radiation. And if you do, it is completely different than, quote, typical chemotherapy and radiation. And it's very important not to go down the wrong path when you're diagnosed and you're waiting to meet your oncologist or your surgeon, and then be careful with the Googling, because of course, neuroendocrine tumors are very different and the treatments are very different. So many of you are probably on this treatment called the somatostatin analog. Many of you know these very well. There are two options typically, sandostatin LAR and somatuline. These are the medicines that are typically used first for many patients because they've been shown to be effective at controlling tumor growth. They're typically very well tolerated, although you see my smiley face at the bottom because it's not your oncologist getting the shots, it's you. And so tolerance is always in the eye of the beholder, but in general, what we hear, and especially compared to many of our other treatments we give in cancer medicine, these are very well tolerated. And as you know, there are excellent patient support programs in Canada for access and treatment. One thing that you should be told is that these treatments can result in your bowels not absorbing fat very well, and so sometimes they can lead to a little bit of worsened diarrhea. And over the long haul, there's a slight risk of gallbladder problems. But most times, patients can stay on these medicines for quite a long period of time. What's next if the disease progresses? And this is where, at every step of the way, you should have your case discussed, ideally, within what we call a multidisciplinary tumor group. because the different treatments that we can bring to your care have different specialties behind them, and we need different expertise to look at things and make sure the next step is the right one for you. So many patients end up having or are diagnosed at the start with liver metastases, spread of the disease to liver. And many of our treatments can be directed directly to the liver. So our colleagues in interventional radiology and sometimes surgery can block blood flow to the tumor, that's this big red thing, through something called embolization or chemoembolization. And that results in basically starving the tumor cells of blood, and they die off. Some other colleagues can give radiation treatment through these microbeads, again through the same blood system, directly into the tumors in the liver. The radiation sits there, slowly releases, and results in, again, cancer cells dying off. Sometimes these tumors can be burnt off through a process called radiofrequency ablation, and sometimes there can be surgery done. So there are a lot of different liver-directed therapies that are sometimes very effective and need to be discussed in a group setting where everything is looked at carefully. I'm just showing you this one example of a patient of mine. If you just look at the big red circles, this was a large tumor on the left side of her liver that was causing her pain and nausea. She was treated with the radiation treatment directly to that area, and this is the result. And you can see it's the same size, but it looks very different, and that's because inside all the tumor cells are dead. And over the next 5 years, that big mass here has continued to shrink after her radiation treatment. So treatment to the liver can be very effective for some patients. Now, another treatment option that we are waiting for anxiously in Canada is lutetium-177, or something called PRRT. Many of you know that in Canada, there have been a number of centers of excellence in Edmonton, in London, Ontario, and in Quebec City that have been able to deliver this treatment. We're looking to expand access throughout Canada, and that's going to also happen soon. I'm going to very briefly explain what this is, and just look at the bottom. Basically, if you look at the tumor cell has these little pockets for something called somatostatin, which is the same chemical that's actually in the somatostatin injections that many people get. PRRT involves giving a radiation molecule that's hooked to somatostatin. It's given intravenously, goes through the blood, it finds the somatostatin pockets on the tumor, it sticks there, and it delivers radiation in a targeted way. So it's targeted radiation therapy, but it's given through the blood. And when radiation is delivered to specific areas, it results in damage to the cells, which has been shown to be very effective at controlling neuroendocrine tumors. But very important, if you think of PRRT, these cells have to have the somatostatin pockets so that the radiation actually gets there. And that's why PRRT is not for everybody. And that's why everybody has to have Octria scan test or gallium-68 test to make sure that they may be candidates for PRRT. And then lastly, what about chemotherapy? So chemotherapy has come a long way in all of oncology. And many of you have heard of a new chemotherapy treatment called CAPTEM. What's made this therapy quite unique, first of all, is that it's entirely pill-based, so no intravenous treatments. And much to for instance, for oncologists who are used to giving some very tough and toxic chemotherapy treatments, CAPTEM has been remarkably well tolerated for many patients. We tend to use this mostly for disease that's progressing more quickly, in particular for patients with neuroendocrine tumors that started in the pancreas. But increasingly, we're using this for a variety of neuroendocrine tumors. And for many patients, it can be quite helpful. And again, the key is also generally well tolerated. When I started my training at the Mayo Clinic, if you look at this graph at the bottom, this was the expectation of benefit from chemotherapy back then. About 20% of patients seemed to benefit from chemotherapy. It was all intravenous. It was a very toxic cocktail, and many patients could not stay on it for very long at all. What's evolved is, if you look at the top, this is the CAP-10 regimen, and remarkably, about 60 to 80% of patients benefit. And because it typically is quite well tolerated, patients can stay on it for much longer than ever before. So this has been a real change from a medical oncology perspective. And then we also have pill form of treatments, and some of you know these. I won't talk in detail about them, everolimus and sunitinib. So if you think about all these treatment options, surgery, liver-directed therapy, PRRT, pill form of treatment that's not chemotherapy, and then chemotherapy, it's no surprise that we need a team to help decide what's right for what person. And what's amazing about neuroendocrine tumors, all of them may be right at some point in someone's disease journey, depending on the situation and depending on what's going on. So, when we can't cure a disease, we have to be very careful that the treatment isn't actually worse than the disease. That's a key element of a lot of the goals of care. And our ultimate goal is to prolong good quality survival and life. And to do that, we have to minimize disease symptoms and complications, but equally importantly, we have to minimize treatment-related side effects. For many cancers, that's very difficult to do. Thankfully for neuroendocrine tumors, it's not always easy to do, for sure, but compared to many other cancers, it's a lot more achievable. So at each time, anytime you come back from a scan, anytime you come back from a test, really we need to ask ourselves a number of questions. Does this patient actually need treatment at this time? Is the change on the scan that we're seeing significant enough to be a threat? Is it significant enough to change a treatment or add a treatment? And for many patients, even if there is a couple of millimeters growth between scans, that might not be enough to change anything, because the longer you can stay on treatment A safely, the more options remain for future treatment. Is there something we can do to target the specific area of disease? We always think about that. What can we do to help the liver? But we have to be very careful that we don't hurt the liver. And how do we balance that out? What about PRRT? Is this patient potentially candidate? Do we have access to it? And when should we use it? And always, are there surgical options? So all these questions you should feel free to ask and should be asked about your case every time you come back from a scan. Finally, last minute or so, many patients understandably want to know, what is my prognosis? And for many cancers, it can be difficult to answer that straight up unless the disease is so aggressive and things are happening so terribly quick, but it's extremely variable. And it depends on where the disease is, what surgery can do, where it started from, what symptoms you may or may not be having, what the growth rate is of the actual tumor, whether or not there is a hormonal syndrome, and as importantly, whether we can control it with our treatments. What is the availability of new treatment options? What is the sensitivity of your tumor to treatment options? And what about your general health and other conditions that you may have that may pose a threat to life? And I hope that illustrates why many times the answers to your very important questions, what is my prognosis, can be very unsatisfactory because doctors typically get this wrong many times, and we're very careful sometimes at putting a set number in, for patients, even though that's an important question, of course. And finally, for many patients, you know, a big question is who is going to help take care of me? And I've already alluded to this multidisciplinary team. And these are the examples of some of the people who ideally we'd be at the table. It doesn't mean that you need everybody at the table every time, but you need someone stick handling your care, quarterbacking your team, bringing in relevant expertise when it makes sense. Not all places can have access to all these specialties right at once, but you should be in a place or have access to these areas of medicine when you need. And finally, the last question. Now, usually, for those of you who have heard this before, you're going to roll your eyes, and I usually say there's a door prize for someone who gets this right. And I don't think I've ever had anybody get this right. And you can't talk to me, so I'm just going to assume nobody's going to get this right. What is a group of zebras called? If anybody in the chat, if they can answer that in the chat, the first one, I don't think we have a door prize, so don't get too excited, but you at least get pride of knowing that you know the answer. It's called a dazzle. Okay, dazzle zebras. You're all a dazzle zebras, and I thank you very much for your attention. I hope this has been helpful, and I'm looking forward to your questions that hopefully came through in the chat.
Thank you so much, Dr. Rayson. That was a dazzling presentation. I really learned a lot, and I know that our listeners did too. We have quite a few questions, so I'll start with the first one that came in.
Sure.
The question is, I would like to know why chemo or something like it is not used after a pancreatomy for a peanut with good margins.
Great question. So what you're referring to now is a concept that we use for many other tumors called adjuvant therapy. And adjuvant therapy means treatment of whatever sort given after complete resection of a cancer to try and minimize risk of it coming back. For colon cancer, for breast cancer, we have lots of data, been lots of studies that clearly show that post-operative treatment will reduce the risk of recurrence. The problem is for neuroendocrine tumors, we don't have any data whatsoever, and that's the issue. It's very difficult to propose a treatment when there's really no evidence, no data at all to support it. And all the treatments can give a lot of side effects. So we want to make sure we know what we're doing, that we're truly benefiting. Great question.
Thank you very much. The next question, I'm wondering if there has been any research around the use of medical cannabis, CBD oil with minimal THC for patients with NETs.
So as many of you know, and to be honest, every clinic, I have at least a third of my patients asking me similar questions across all kinds of cancers. And this is what I tell them. Medical cannabis or cannabis can be very helpful for a set of symptoms that are usually focused on pain, nausea, fatigue, loss of appetite, and sleep. And for some patients, they can start cannabis and get rid of a half dozen other conventional medications. And there are now cannabis clinics that can help guide patients. Even I have patients who are in their mid-80s on cannabis for symptom control. What is difficult is to understand exactly what cannabis does at the level of the cancer cell. Huge research question now. Lots of information we don't know. We will likely be much smarter over the next 5 years or so. But what I tell my patients is we have to keep the expectations realistic. Right now, there's no clear evidence that cannabis will actually have an anti-cancer effect. We have to be careful. Cannabis is a big, there's a lot of hype around it. So Bottom line is that question applies to all kind of cancers, not specifically to NETs. So no specific research in NETs that I'm aware of, but can be very helpful for certain patients.
Thank you. Next question. I continue to hear, whoops, my chat keeps moving. I continue to hear that it is imperative to have a NET specialist, excuse me, as opposed to an oncologist. When I asked my oncologist, she said she has other NET patients and seemed surprised that I questioned her. Is there a way to ensure that an oncologist is well educated and can be assured they are updated on NETs?
Yeah, that's a very fair question as well. And I just want to be very open. Many oncologists can take excellent care of patients with neuroendocrine tumors. What I mentioned with the multidisciplinary team is they should be able to access relative specialists when they need and when they have questions. That is really the key. So for example, in Atlantic Canada, we have in Halifax a very well-trained group, and we interact with colleagues from New Brunswick, from Prince Edward Island, from Newfoundland all the time, giving advice, presenting cases. I personally may never see the patients being discussed, but their oncologist is reaching out when he or she feels the patient needs further input. So I never want to state, there are some excellent oncologists who are interested in this disease, who can take beautiful care of patients with NETs. I think the key is to ask, if you're uncertain or if you think I might need treatment A or B, do you have someone you can call for advice or guidance? And of course, you state that in a very gentle way to keep, because it's a very fair question. And I think that's the key. Canada's a huge country. The geography doesn't help us. Not everybody can be in downtown Toronto or Halifax. Us as oncologists, as our team, we have to do a job reaching out so that the whole country is covered with at least patients and oncologists having access to perhaps subspecialty expertise.
Thank you very much. Well said. Next one. Although not available in Canada, is the Wren Laboratories NET test better than chromogranin A?
They do different things. So every test has limitations. Every test has variability. Every test has limiting factors. So I wouldn't say it's better than, it just is different. Yeah.
Okay. What is the likelihood of PRRT working for lung NET patients?
So the best data we have with PRRT is for patients with NETs that started within the small intestine. That's where we have the clearest evidence, the clearest data. That's what's led to a global push to bring PRRT to general oncology care. We don't have that level of evidence for NETs of other origins, except for certain centers in Europe that have treated patients with PRRT for many, many years. The problem with lung NETs, as I mentioned when we talked about PRRT, in order for PRRT to be helpful, the tumors have to have enough of those somatostatin pockets for the liquid radiation to find and to stick to. Many patients with lung NETs, that's not the case. So, and that's the limiting factor. It doesn't mean that PRRT can't be helpful if a patient with lung NET does have a very strong positive Octria scan or a gallium-68. It just means fewer patients with lung NETs are likely to benefit, not just because of that issue.
Next question. Thank you, Dr. Rayson. Very well presented collection of useful information. Can you list the ideal members of a multidisciplinary team for neuroendocrine tumors by specialty? I have had difficulty with complementary specialists deciding on whose recommendation should take the lead. Finally, how do you recommend we as patients can advocate for ourselves with our research knowledge without distancing the professionals? Thank you for your help. Cheers.
Oh, two easy questions. So I think I think if I can just, I don't know if my slides are still up. If you can see the list that I've, can you see my slides still now, Lynn? Is that still there?
Yes.
Okay. So I hope that helps answer the first part. But again, I think the key, it doesn't matter, to be honest. Well, let me step back for a second. There's really, I would say there's a key member. The key member is the one who's actually going to take care of you and to coordinate everything. That is the key. They can be a surgeon, medical oncologist, unlikely to be a pathologist and radiologist, of course, but could be an endocrinologist, gastroenterologist. The key is for every patient to know who is their go-to person, because it is true. You see this slide with the blind man and the elephant.
Mhm.
The different perspectives can sometimes be very, very difficult to reconcile, and you need absolutely someone to take charge of coordinating things and to give a coherent framework. Very, very important. Usually it ends up being a medical oncologist or a surgeon, simply because they're the ones that have the most hands-on clinical care interactions. As far as advocating, as the question stated, it is a difficult road, and I think a lot depends on your relationship with the go-to person, I think. And my view is you have to feel comfortable bringing your questions, even if they're challenging, to that person, and feel that they are listening, and at least if they don't have the answer, they know where to go. You know, it's difficult to answer that question any more specifically, but advocacy is important. I think at some point, for a patient, there's got to be a final plan. So again, for some, with all the different perspectives, patients can get really lost in all the different opinions. You need to find someone you can trust, who gets to know you, you get to know them, and it could be just a single person somewhere in a small town. That's okay, as long as they have access by phone, it's not high tech, to some of these others.
Thank you. Is the increasing incidence of NETs consistent across Canada?
Yeah, interesting. We have no reason to think it isn't. I think that's the fairest question. Again, I showed you the best data we have is from Ontario, but really I think that, and again, what I mentioned is that we think the increased incidence is simply because everybody's getting trained up through groups like CNETs, through different specialties that have really taken an interest. Neuroendocrine disease used to be lost in the field of medicine. That's no longer the case. So it, you know, the tide has raised all boats, if you will, and it should be the same across Canada. We don't have any evidence to the contrary.
Thank you. What therapies are offered to patients with primary lung NETs that has metastasized to Bones disease?
Well, they can be quite similar to the series of treatments I had mentioned. Again, lung nets is a little bit different again. So there are three categories of lung nets, one of which is extremely slow growing and sometimes not growing. And it can span to a very aggressive type where typical cancer chemotherapy needs to be given, called small cell lung cancer. So it again really depends on the situation, but many of the treatments, both the somatostatin analogues, a pill called everolimus, sometimes CAPTEM, the chemotherapy, and sometimes PRRT, can all be potentially helpful depending on the situation. Again, and the problem with lung nets is compared to nets of small intestine or pancreas, we have much less data to inform us exactly how beneficial some of these treatments can be. But they can all be options.
Okay. Will every patient have uptake on the gallium-68 scan?
No, no, that's an interesting question. Gallium-68 is much more sensitive than Octreoscan, as I showed you. There will be more patients who have positive gallium-68 versus Octreo scan, but there are some diseases that simply will not have any uptake, and those are typically the ones with all those brown dots, with very high Ki-67, a more aggressive disease.
Okay, I think we've come to the end of the questions, unless we want, unless someone out there would like to type one in quickly. I'll give you one more minute. Okay, one more. Dr. Rayson, can you please expand upon the GA68 effectiveness for lung nets? Looking at your previous slide, it appears its effectiveness is in mid-grade, stage 2, but does origin also affect outcome? Why do you believe there is less focus on lung net than other primary sites?
So again, gallium-68, just like Octreoscan, depends on the cells having those little pockets for somatostatin. They work the same. And so the problem is for lung nets in general, there are fewer lung nets that have somatostatin pockets or receptors as compared to nets of small intestine or pancreas. That's why Octreoscans and gallium-68 may be less commonly positive in lung. Site of origin may, and again, it's a good question, may or may not dramatically affect outcome. It's more the biology and the grade and the treatment sensitivity, in my opinion. So it's not that a priori lung nets outcomes are X amount worse or better than PNET outcomes. Every case, it falls into different categories, and it's more the biology that dictates outcomes rather than just where it started. And I'm not sure if I caught, there was a third element to that question. I don't know if I covered it.
Well, the last one part was, why do you believe there's less focus on lung nets than other primary sites?
And less focus. So it's interesting in Halifax. So I see patients with nets of any origin, doesn't matter. But in oncology in general, we have the gastrointestinal team and we have a lung team. And a GI doctor, oncologist, typically does not see patients with lung disease. And so NETS spans all these organs. And so historically, different people looked at different, take care of different organs rather than the full spectrum of disease. And historically, lung nets have been thought to be so different from typical lung cancer that there was not a lot of interest in the lung group anywhere. And that's probably why there's been just less work done on lung nets. It's changing, no doubt, but that's the history.
We have 2 minutes left. Can slow-growing tumors change to fast-growing?
Interesting. So we never say never in medicine. We definitely never say never in nets, but typically not. So typically, if a patient is being followed for a slow-growing tumor for a period of time, and we're confident that we understand the biology, in other words, let's say 2 years, minimal change, it is extremely improbable that all of a sudden will change into a fast-growing tumor. But some patients, you saw that those spectrum of those brown spots. Now, when we take a biopsy, that's just one biopsy, that's one sample. We know that if we took 20 biopsies of 20 different spots in a body, we'd get different results. So sometimes in the same patient, there's a mix of slow growing and fast growing. We may not know that at the start. We may learn that in the future. And so there can be a change in behavior, not so much that the disease changed radically, but that different elements of the disease are being expressed.
Okay, I'm going to wrap it up there. We have a comment that was a very informative presentation, and thank you. And I would just like to echo those words. It's been very gracious of you to give us this hour of your expertise and your time. And I know that everyone that was online really appreciates it. I'd like to thank Rico and Jackie Herman for instigating these webinars, because I think they have filled a need, and I think they've been working really well. So best wishes to everyone out there, and thank you for joining us today. And I'll sign off at that point.
Thank you very much, everybody. Thank you, Lyn.
Thank you.